In Lecture 4 of Module 1, we're going to discuss several things. Our module learning objectives for this lecture include define the mechanical cardiac cycle of the heart, including systole and diastole. Relate atrial kick to ventricular filling. Identify the components of cardiac output, including stroke volume, heart rate, and ejection fraction. Use the formula for cardiac output to determine how the body compensates for increases in oxygen demand on the heart. Relate the Frank-Starling mechanism to cardiac output. Identify factors affecting venous return. Identify factors affecting cardiac output. Define preload and variables that may affect it. Explain how preload affects venous return. Define afterload, and explain how afterload can affect cardiac output. So to start the lecture off, I'm going to show a quick video on the cardiac cycle.
This animation illustrates a single cardiac cycle, starting with the right side of the heart. In reality, of course, the two sides of the heart work together at the same time, but it is easier to understand if we look at them separately, because each side of the heart has a different function. The cardiac cycle begins as deoxygenated blood flows from the body into the right atrium via the superior vena cava and inferior vena cava. In the next phase of the cycle, the right atrium contracts, pumping blood into the right ventricle through the tricuspid valve. Once the right ventricle fills with blood, the tricuspid valve closes to prevent blood flowing back into the atrium. The right ventricle contracts, forcing the pulmonary valve to open as blood is pumped into the pulmonary artery. Blood then travels to the lungs and the pulmonary valve closes. At the same time, the right atrium relaxes, ready to accept the next intake of blood. In the lungs, the blood picks up oxygen and releases carbon dioxide. Oxygenated blood flows from the lungs into the left atrium via the pulmonary veins. The left atrium contracts to pump blood into the left ventricle through the mitral valve. Once the left ventricle has filled with blood, the mitral valve closes. Next, the left ventricle contracts, forcing the aortic valve to open, allowing blood to be pumped into the aorta and from there around the body. The aortic valve closes to prevent blood flowing back into the left ventricle, and the left ventricle relaxes, ready to accept the next intake of blood. Cardiac cycle is now complete.
So remember, when we're talking about the cardiac cycle, you got to remember that the heart and the cardiovascular system is a closed system that depends on forward-moving pressure to move the fluid out. All right. So when we actually talk about cardiac output here in the next few minutes, we need to remember that everything that we do in cardiology goes back to cardiac output. Whether it's electrical issues or mechanical issues, we've got to figure out what is affecting the forward moving of the pump. What is affecting the heart pumping blood moving forward. And so all of your valves, like they just mentioned here, they work in a series in order to keep blood moving forward. So the cardiac cycle itself represents complete depolarization and repolarization of the atria and the ventricles. Now keep in mind, repolarization and depolarization, when related to this class and what we're going to learn, are electrical terms. So we're going to think of systole and diastole as resting and contracting, physically resting, physically contracting. So diastole is going to be the moment when atria or the ventricles are resting, and systole is going to be the moment when atria or ventricles are contracting. And understanding the basics there is going to help you understand the next terms that we're going to talk about here in a few minutes. There's a process with everything that happens with the heart. And even in the cardiac cycle, the term systole and diastole, as we use them, refer to ventricular systole and diastole. Think of the phases in which the blood would be in the ventricles. So during late systole, the atria are full, but the ventricles are empty. In early diastole, so in early resting or ventricular resting, this is when the AV valves open, allowing a large amount of blood to rush into the ventricles, which rapid filling occurs in diastole. Mid-diastole, the ventricles are full and the ventricular walls are not yet distended. And at the end of diastole, the amount of blood in the ventricles is ready to be squeezed out. But again, this is the rest period. But the atrial kick allows an extra amount of blood to enter the ventricles, allowing them to stretch and overfill. So let's talk about the atrial contraction, and the atrial kick will come back up. So during atrial contraction, the blood in each atrium is squeezed into the respective ventricles. So during ventricular diastole, the atria are pushing blood into the ventricles. So if you think about the anatomy of the heart, you'll remember that the atria is on top of the ventricles, right? So the atria are not very muscular, so they don't have a real strong squeeze. They depend heavily on the AV valves opening and gravity pulling the blood into the ventricle. But at the very end, there's the last moment where whatever's left in the atria, 10 to 40% of the blood that needs to go into the ventricles, is squeezed out. And this is called the atrial kick. So it allows blood to go through, and then it kicks and pushes the rest of the blood into the ventricles. So after the ventricles are full, we're going to go into ventricular contraction or ventricular systole. At this point, the AV valves, or the atrioventricular valves, are both closed because that's keeping the blood from moving back into the atria. As ventricular contraction begins, the ventricles contract, and at this point, the semilunar valves, both the pulmonary semilunar valve and the aortic semilunar valve, are open because remember, both chambers squeeze at the same time. Blood from the right ventricle is squeezed into the pulmonary arteries. This is your deoxygenated blood squeezed into the pulmonary arteries to go to the lungs. And then the left ventricle blood, which is full of oxygen, is pushed into the aorta. So as we're moving forward, think about the left ventricle has to overcome the pressure in the aorta in order to push that blood out to the rest of the body. So here's some new terms that we need to remember because these are going to continually come up in this class. Cardiac output. So cardiac output is the amount of blood pumped by the ventricles in 1 minute. Stroke volume is the amount of blood pumped by either ventricle in a single contraction. Your heart rate is the number of contractions per minute, and then another term, ejection fraction. So ejection fraction is the percentage of blood leaving the heart on each contraction. So essentially, ejection fraction and stroke volume are not measuring different amounts of blood, they're just measuring in different units. So stroke volume is measuring in volume, whereas ejection fraction is measuring in percentage. Just for reference here, the normal cardiac output for the average adult is 5 to 6 liters per minute. So if you remember from past lectures, we said that on average, the average adult has around 5 liters of blood. So that's saying that the normal cardiac output for the average adult is 5 to 6 liters per minute, or the full amount of blood volume in the body. So your normal left ejection fraction is 50 to 70%. So what does that mean? That means that the ventricles do not squeeze out every ounce of blood during every contraction. Why? Because they have to stay primed. The heart is a prime, or the heart is a pump, and it has to stay primed. So just like a balloon, if you filled it with air and you let all the air out, the walls of the balloon would squeeze together or stick together. The heart would do the same thing essentially. If you pushed all the blood out, you would lose your prime, and then you would not be able to push the blood out. The formula for cardiac output: stroke volume, so the amount of blood with each stroke, times heart rate, or how many times your heart beats per minute. Now, what happens with cardiac output is that the body changes a variable of this equation in order to meet the demands of the body at the moment. So it increases cardiac output by either increasing stroke volume or increasing heart rate, which is usually what the first thing is. When the body has more of a demand of oxygen, it increases heart rate, or it does both. And this is going to be stimulated by the sympathetic nervous system. The Frank-Starling mechanism, Starling's law, basically says the greater the stretch, or the greater the stretch, the tension on the walls of the ventricles, the greater they are going to force blood out. So when the myocardial fibers contract more forcefully, when they are stretched out, you're going to have more blood pushed out. When the ventricles are filled with larger than normal volumes of blood, which is going to be increased preload, which is a term we're going to talk about shortly, they contract with greater than normal force to deliver all blood to systemic circulation. Question for you. Think about it. How does the behavior of a latex balloon resemble myocardial fibers? Well, I mentioned it just a little bit, but if you think about a balloon, the elastic balloon, the myocardial fibers are designed to be elastic as well, and you've got hollow chambers that are designed to expand when more blood is put into the hollow chambers, and just like the balloon is designed to expand as more air is blown into it. However, when released, if you've got a little bit of air in the balloon, it will only go a short distance. But if you put more air in it, you stretch the walls of the balloon more, and it will go a longer distance. So the force of contraction of the heart's muscle fiber is greater when more blood fills its chambers, resulting in more blood being squeezed out with each beat, i.e. Starling's law that we just mentioned. So the heart increases stroke volume in several ways. One is increasing preload, or the Frank-Starling mechanism. When cardiac muscle is stretched, it contracts with greater force. If the heart rate is constant, any stroke volume increase will increase overall cardiac output. And this is just giving you kind of an example of what happens with muscle. So unstretched muscle has less tension than stretched muscle, but if you put that tension on it, if you stretch it out, it has better functionality. But the most important thing to remember when treating a cardiac patient, your main objective, no matter what the etiology is to restore cardiac output. The body likes its numbers. It likes its numbers. It likes to pump out the same amount every time. Poor pump equals poor perfusion. So a couple of new terms here. Preload. Preload is the volume of blood in the ventricle at the end of diastole, or end diastolic volume. It's a reflection of venous return. So that's the book definition. The way that I want you as a paramedic student to relate preload with the heart is going to be really the measure or the volume of blood that's coming back to the heart. So the amount of blood available to come back that's going to be available to be pumped out. Now, afterload, you would think might have to do with volume, but it doesn't. It actually has to do with force or pressure. So afterload is the force against which the ventricles must contract to eject blood. In diastolic volume, or preload, is the volume of blood returning to each ventricle. So the volume of blood that's going to be available for contraction. So if you have less preload, then you're going to have less volume going out. What goes in goes out. What doesn't go in doesn't go out. This normally reaches about 120 to 130 milliliters, and then as the ventricles empty during systole, their volume decreases to 50 to 60 milliliters, or the end systolic volume. So again, remember, the ventricles don't pump out all of their blood. The normal person has an ejection fraction in the 60s or 70s. There's still going to be about a quarter of the blood left in the ventricles at the end of systole. Preload is influenced by the blood volume returned to the heart. So more blood is returned when more oxygen is demanded, and the Frank-Starling mechanism is used to achieve normal resting cardiac in a diseased heart. With a constant stroke volume, cardiac output can be increased by increasing the number of contractions per minute. The degree of contraction can vary without change of contractility. A healthy heart capacity to increase stroke volume is great. If large amounts of blood flow into the ventricles during diastole, their end diastolic volume, or preload, can be as much as 200 to 250 milliliters. In this way, stroke volume can increase because, remember, the greater the stretch, the greater the contraction, the greater the force out. The ability of the heart to pump more strongly when it has larger preload, again, is explained by what? Starling's law of the heart. Afterload would be the pressure within the aorta prior to ventricular contraction. So essentially, it's going to be the amount of pressure that the left ventricle has to overcome in order to push blood out of the left ventricle into the aorta and allow the aorta to transport the blood to the rest of the body. This is a result of peripheral vascular resistance. So you can think of afterload and peripheral vascular resistance as very, very similar, which is a total resistance against which the blood must be pumped. The more afterload, the more difficult it is for the left ventricle to pump blood to the body. In this case, think of the relationship between hypertension and afterload. Why is hypertension so important to control? If the patient is experiencing hypertension, or high aortic pressure or high arterial pressure, then the left ventricle is going to have to work harder to push blood out, which is going to lead to a decrease in stroke volume due to the increased pressure in the aorta that the ventricle has to overcome. And this is actually going to cause the heart to work harder, and it's going to actually lead to heart failure eventually if hypertension is not controlled. And although the term afterload is most associated with the left ventricle, think about how this term could be associated with the right ventricle. And that would be afterload on the right ventricle is going to be the amount of pressure that the right ventricle has to overcome to push blood out of the pulmonary artery. And so this is where terms like pulmonary hypertension come in. The pulmonary artery usually has very small amounts of pressure. As afterload is decreased, stroke volume increases. So again, that's the relationship between hypertension and afterload, which is an example, but there's other things that can affect increases in pressure as well. So just as a quick review of preload and afterload. Preload is the volume of blood in the ventricles at the end of diastole. So end diastolic volume, the amount of blood that's available to pump out when systole kicks in. Things that affect preload: hyper or hypovolemia, and also regurgitation of cardiac valves. That's why it's so important for those cardiac valves to stay closed. And then afterload is a resistance the left ventricle must overcome to circulate blood. Afterload is going to be increased in things such as hypertension and vasoconstriction. And so one very important thing to remember: increased afterload equals an increased workload on the heart as a whole and the whole cardiovascular system. So in recap, very important to remember, the heart works together with its electrical system, with its mechanical system. And cardiac output is very important to the body. So everything that we're going to treat in cardiology, or cardiac disease processes, is going to relate to how do we fix cardiac output. What part of the equation, stroke volume times heart rate, must be adjusted in order for us to get blood out of the left ventricle to the rest of the body. And this concludes lecture 4. Please let me know if you have any questions.